Couple of new colleagues joined us first time. So welcome everyone. Thank you for joining. We're very pleased to have Dr. Alonso with us today. Dr. Almudena Alonso is attending neonatologist in Cadiz in Spain. Her PhD was about usefulness of lung ultrasound in PPD. She has different publications on neonatal lung and diaphragmatic ultrasounds, mainly about the use of lung ultrasound in monitoring very preterm infants during their stay in neonatal intensive care units. She is a coordinator of the Spanish group for the study of BPD using lung ultrasound, which includes more than 10 units. She's also the coordinator of the respiratory section in the POCUS group of the Spanish Society of Neonatology. She's also in the POCUS group of the ESNIC, and she's an international speaker. So welcome and thank you for joining today. Over to you, Almudena.
Thank you, Mahmoud. Let me share my screen. Okay, can you see it? Can you see my screen?
Yeah.
Okay, thank you. Well, the talk of today will be about using lung ultrasound for monitoring haemodynamically significant PDA in very low birth weight infants. Let's see if this works. Yeah. We'll talk very briefly about the effects of PDA on the lung and the different monitorization of different ultrasonographic signs that we can find in using lung ultrasound in very low birth weight infants with or without HA's PDA. And also a few words about how can we use lung ultrasound to monitor edema after PDA closure. We all know that PDA is very frequent and appears after the third day of life in most infants born before 38 weeks at birth. This would lead to an increase in pulmonary flow in this infant, pulmonary edema, as well as respiratory deterioration in their situation, in their basal situation. We know that many different treatments have been essayed to try and reduce this edema and close PDA. Many approaches have been used, like targeted prophylaxis in the very first hours of life in infants at risk of developing PDA, early treatment in the first hours of life, and treatment of symptomatic infants afterwards, or late or rescue treatment. However, none of these approaches have been able to show a reduced incidence of BPD using any of these approaches till we get to the fact and this multi-center trial published last year in which they demonstrated that the expected management was similar to use early ibuprofen in infants with risk of PDA or with PDA in the first hours of life. So nowadays, still the treatment is very controversial, and there are different protocols according to different in each institution. So the idea of this session was not talking about treatment of PDA, but how can we use lung ultrasound to monitor the effects of the PDA in the preterm lung? For those of you that are not really very fond of the science of lung ultrasound in neonates, we would say that if we want to rule out or rule in lung edema, we have to find a thin pleural line, as you can see here, an increase in the number of B lines. The more B lines, which are these vertical artifacts, hypergenic vertical artifacts that we see arising from the pleural line, the more B lines that we found, the more edema or the more extravascular lung water the patient has. So using this definition, there have been different publications, mainly in the child's world, comparing the diagnostic accuracy of lung ultrasound and chest X-ray, as you may see here. And all of them get to the point that lung ultrasound is more sensible, more specific, has a higher negative predictive value and higher positive predictive value. So if we try to diagnose lung edema using lung ultrasound, will have more success than if we just use X-ray. So this is the reason why we all think, or we all may think, the lung ultrasound can be useful for monitoring hemodynamically significant PDA in very low birth weight infants. However, we have to take also into account that these patients, mainly in the first days of life, do also have another disease or may have another disease which have very similar ultrasonographic signs compared to lung edema, which is respiratory distress syndrome, as you all know. Almost all patients born before 39 weeks will suffer RDS. Almost 35% can be described in some series. And this, you can see, this is the first article that describes ultrasonographic signs of RDS in preterm infants. This is a disease that mainly is characterized by an increase in the number of B lines, as the one that we've seen before in relation to lung edema. However, there are some slight differences, like the thickness of the pleural line or the existence of consolidations that can make us differentiate just water or an RDS. And apart from the first days of life, we also know, and this is something from a paper published in 2019, that all very low birth weight infants, after the first days of life, and these are serial ultrasonographic assessment performed in infants born before 32 weeks of life. In the first days of life, due to the fact that they usually have RDS, they will have higher lung ultrasound scores in any kind of infant that we evaluate initially. But after that, those that develop BPD will still have persistently high lung ultrasound scores after the initial phase of RDS. And this is true not only for those patients with RDS, but if we analyze those born before 38 weeks at birth, if they don't have RDS, they will either have an increase of lung ultrasound scores after the first week of life due to the fact that they have this entity called respiratory instability of prematurity. So as you can see here, even those that don't need surfactant at birth will have an increase of lung ultrasound scores irrespective of the final diagnosis of BPD. And taking this into account, I will now explain or review the main evidence published relating to lung ultrasound and PDA in very low birth weight infants, and some words about what I think we should be aware of. This is the first article published with this aim in 2029 that included all preterm infants born with a birth weight less than 1,500 grams that were admitted in the first 24 hours of life. They analyzed both in upper anterior, lower anterior, and lateral fields the lung ultrasound score, which is a semi-quantitative score that maybe you all know, that quantifies with these values the amount of aeration that the lung has, in terms that normal aeration will be described like 0, 1 will be an increase of B lines separated between them, 2 will be a completely wide lung with so much B lines that we cannot differentiate them all, and the big consolidation like this one here will be ranked like 3 points. If we zoom the value obtained in each of these fields in both lungs, we can get a semi-quantitative assessment of lung aeration. So using this approach, this group of authors analyzed both echocardiography and lung ultrasound score performed at 4 days of life in 2 groups, one group of infants with PDA and one group with infants with closed ductus arteriosus. They didn't define haemodynamically significant PDA and just the persistent or closing of the ductus arteriosus. Both groups had similar gestational age and birth weight, but as you can see, those with a PDA had higher lung ultrasound scores compared with the control group and higher ratio between left atrium measurements and aortic root. But we have to take into account when we see these results that the authors didn't give any kind of information about the respiratory situation of these infants at the moment when the exams were performed. So we cannot assume that this is just due to the PDA. The next paper published later this year included 46 patients born before 32 weeks. They also calculated lung ultrasound score, but we don't know really in which fields because this was not explained in the article. And they evaluated 26 infants at day 1, 14 at day 2, and 8 at day 3. And they divided them according to the existence or not of haemodynamically significant PDA in terms of diameter. Well, they define haemodynamically significant PDA when they have a diameter of the ductus higher than 1.5 millimeters, or a ratio between the diameter and left pulmonary artery higher than 0.5. And they have to find at least one of these four: a ductus flow velocity less than 0.25 millimeters per second, mean pressure gradient less than 8 millimeters of mercury, left pulmonary artery diastolic flow velocity higher than 0.2 millimeters per second, or reverse diastolic flow in descending aorta. They also measure, apart from echocardiography measurements and lung ultrasound score, both thoracic flow contact and left ventricular output using this device, which is not, left ventricular output was not measured using echocardiography. And they compare the results between the two groups, and they also got higher lung ultrasound scores in the group with haemodynamically significant PDA, higher thoracic flow contact, and high left ventricular output, as well as the other article. I may say that in this study, they described that the patients that were in invasive mechanical ventilation had higher values of lung ultrasound scores. But we don't know in this article any reference about the respiratory situation of this group compared with this group, which is also a difficulty to interpret these results. The last study, published also this year, used more or less the same approach, but they only analyzed infants born at 25 weeks or younger, and they calculated a different lung ultrasound score compared to the previous ones, which has 5 categories, as you can see here. And it was evaluated in 6 areas in each lung, so 12 areas as a whole. And the score then ranges from 0 to 48, and it was evaluated at 4 days of life. They created as well 2 groups. They created the one with a restrictive ductus arteriosus and those with open ductus arteriosus, and this one of these 3 aspects, like ductal diameter higher than 1.5 millimeter, a ratio between left atrium and aortic root higher than 1.5, or reverse or no diastolic flow in the ascending aorta. Using this lung ultrasound score and with this categorization, they describe this area under the curve for the use of lung ultrasound to distinguish haemodynamically significant PDA. In this group, they also give us a bit more information about the general situation of both groups of patients. And as you can see, although had similar incidence of mechanical ventilation, the group with haemodynamically significant PDA had higher lung ultrasound score. And as I explained before, the difference is 8 points in a score that ranges from 0 to 48. Maybe this difference is not that clinically significant. I will now present 2 more studies that were not published or were not designed to describe lung ultrasound in ductus arteriosus, but maybe can give us a bit more information or different insight of what can be done. This one published in Archives of Disease in Childhood 2022 by Australian group was designed to predict BPD using lung ultrasound, but they also studied the effects of PDA in the lung, and this is why I'm going to show you again as well, sorry. They also measure lung ultrasound score in upper anterior, lower anterior, and lateral field, but there, as you can see, created a completely new lung ultrasound score compared to the others. They use different 7 categories, completely different to the other ones, and some of them a bit more tricky because, in my opinion, are in different order in terms of different aeration of the lung. However, in the supplementary material, they have this graph in which they just compare the existence of a PDA and a closed ductus arteriosus. And you can see that both in day 1, day 3, 4, and day 7, there were significant differences between those with a PDA and those with a closed one. However, after that, in day 28 or 36 weeks post-menstrual age, there were not significant difference between the two groups of patients. And the last one is this multi-center trial performing in many Italian NICUs, published in Pediatrics 2021, that also aim to describe the evolution of lung ultrasound score in very preterm infants after the first days of life. This is a graph of those born between 25 and 30 weeks. As you can see, that those without significant morbidities were in dark gray, have a decrease of lung ultrasound scores after the first days of life. Those with BPD in middle gray have an increase, a persistently high lung ultrasound score that decrease after 1 month of life. And those with other complications different than BPD, which are the lightest gray, have also a lung ultrasound score higher, but the decrease begins sooner compared with BPD patients. And what kind of complications are related here? The authors included sepsis, PDA, pneumothorax, and pulmonary hypertension. In the definition of PDA, they had a PDA that required medical or surgical treatment, but we don't know more about this. We also don't know about the respiratory situation of these infants, and maybe some infants with this definition of BPD were also included in the category of infants with BPD as well. So taking a summary of these articles that I've presented, we may say that all were more or less performed in the first days of life. They included infants with different gestational ages at birth, and they had different definitions of PDA, as usually happens. But apart from the third study that described the number of patients that were on invasive mechanical ventilation, none of them describes anything about the respiratory situation of the infants. And the second one also included distinction between infants that were on invasive mechanical ventilation and non-invasive mechanical ventilation in terms of lung ultrasound score and thoracic fluid content. But however, we know, and this is something that we published last year, it's a multi-center study performed in different Spanish NICUs, that the progression of lung ultrasound score is different according to the gestational age of the babies at birth. As you can see here, all infants that still need oxygen at 36 weeks post-menstrual age do have persistently high lung ultrasound scores, but those that don't, the evolution of lung ultrasound score is different according to their gestational age. As you can see here, the more immature infants do have a persistently high lung ultrasound score in the first month of life, and this decrease afterwards, although they don't develop BPD. However, those more mature that don't develop BPD do have a persistently reduced values after the initial phase of RDS. And this is more or less some examples of what we can see here. This is a baby born at 24 weeks, which is who is now at 2 weeks of life. She has she's an evolving BPD, but also an hemodynamically significant PDA that was receiving treatment in that moment. And as you can see, both in the anterior, lateral, and posterior fields, we see alveolar interstitial pattern with a thick pleural line, small consolidations, and lots of B lines all over the lung. You can see these artifacts, these vertical artifacts arising from the pleural line that we explained can be related to lung edema, but also can be related to the situation of evolving BPD as well. However, let's see if you can find some difference between this other patient. This is a 27-weeker that had a closed PDA, and he's 2 weeks old now. But however, he was born after a premature oligoamnios and pulmonary hypoplasia. you can see that at the same moment of life, he had very similar lung ultrasound, probably related with the evolving of BPD that his lungs are having, not to the existence of lung edema. And all this is to make you understand that the progression of the lung in a very low birth weight infant is very similar in those that have an evolving BPD and those that have a PDA, which most of them usually are developing a BPD as well. However, this is a 30-weeker baby born at 30 weeks of life, which is now 2 days of life, still on the RDS. He is intubated, but you can see now that his lungs look really quite the same as the other ones, still along with lots of B lines, high lung ultrasound score. And this was, in this case, this was related to a big ductus arteriosus that this patient was having. Though this patient didn't receive treatment for this PDA, on the 3rd day of life, you see how his lungs are getting better and getting more aerated. And this corresponded as well to a closing of his ductus arteriosus. So the conclusion of this will be that we cannot evaluate the same a lung of a baby born after 28 weeks that a baby who's born before 28 weeks in terms of trying to guess the amount of extravascular water that that patient has in his lungs. So taking all this into account and that we know what is the accepted definition of a hemodynamic significant PDA, and we also don't know normal values of lung ultrasound scores in very low birth weight infants because they depend on gestational age of the babies, it's very difficult to differentiate a B profile, which will be this image, in a very low birth weight infant with hemodynamically significant PDA that those from an evolving BPD. I just wanted to present some results of a pilot study that we performed last year and that we presented in the past meeting this year in Washington that included serial evaluation both with echocardiography and lung ultrasound score in the same day. Those are infants born before 32 weeks, sorry. And we measure both PDA parameters, transductal diameter, direction of the shunt at the level of the ductus arteriosus, maximal systolic and diastolic velocities, left pulmonary artery and diastolic velocity, and ratio between left atrium and aortic valve annulus, and also some left ventricular function measurements like mitral E and A waves, mitral E prima, I prima, and S prima velocities, mitral also volumetric contraction and relaxation time, mitral ejection time, and myocardial performance index. So we wanted to see if there's a significant correlation between these variables and the value of lung ultrasound score. And we created 2 groups, those mature babies and born between 28 to 32, and those babies born before 38 weeks. Lung ultrasound score was performed using the classical approach, upper anterior, lower anterior, and lateral, and the values were from 0 to 3. And we included 69 patients with 159 pairs of echocardio and lung ultrasound exams. The median gestational age was 38 weeks with this birth weight. Sorry? No? And 21 of them developed BPD finally. You can see that most of the ultrasounds were performed in the first month of life, but there was a range of moments when the ultrasounds were performed. And in the first group, which were those born between 28 to 32 weeks, we included 41 patients with 122 pairs of ultrasounds. There was significant difference in the terms of shunt at the level of the ductus arteriosus in terms of lung ultrasound score. And there were significant correlation between, for example, lung ultrasound score and ductal size, although with very weak correlation, very reduced clinical significance, and also significant correlation between the other measurements that I've described before. However, if we take into account the other group, those born before 28 weeks, that also had 35 pairs of ultrasounds, we didn't have significant differences in terms of shunt of the ductus arteriosus, neither with either of the measurements that I've described before. And this is maybe, probably, I think, that due to the fact that this progress, as I've explained before, is different. So we already have this persistently high lung ultrasound scores in infants born before 38 weeks. So if we add lung edema, it's very difficult to be differentiated just using lung ultrasound in this population. And the idea is this. This is the normal, most of the cases, this is the normal progression of a 24-weeker at 2 months of life, 2 weeks of life, compared to an infant born, for example, at 30 weeks of gestation. And after this, I also wanted to give you some clues. Maybe you've already read this publication. This is a case series of 5 barely ovarian infants that had PDA ligation in Ohio. And they compare lung ultrasound score, the classical lung ultrasound score, before and after the procedure. The infants were born at the median time of 25 weeks with this birth weight, and they had a PDA closure at the median time of 41 days. As you can see here, both lung ultrasound score, which are the lines, and left ventricular output decrease significantly after the first hour, in the first hour after the procedure, and remain significantly lower at 6 hours afterwards. So as a conclusion, we would say that the B profile in very low birth weight infants might be related to PDA or to RDS in the first days of life. However, after RDS, lung ultrasound scores may be a sign of lung edema related to a PDA, but we have to take caution in infants born before 38 weeks because lung ultrasound score maybe does not differentiate this hemodynamically significant PDA in the lungs. However, we maybe can use this approach to monitor response to PDA treatments, although we need more articles that confirm the results that I've presented you because it was just a small case series. Thank you very much for your attention, and I hope that you have some questions.
Thanks, Almudena, for this excellent talk. That was fantastic, as usual. We'll just open the floor for questions. So if anyone has questions, please, you can open the mic and camera and ask directly, or if you want to put it in the chat box. So until we get some questions, I might ask a question if that's okay. So Almudena, you mentioned in the publication about the duct ligation that the lung ultrasound was corresponding, the lung ultrasound score was corresponding with reduction of LVO post-ligation in the first hour. So do you think we can use it as a predictor for the post-ligation syndrome that we can predict this is going to happen and act accordingly to get kind of heads up that this is going to happen and start some inotropic support?
Yeah, well, maybe, we don't know. I would say, I don't have data to refute this, but I would say that in my small experience, when I've seen some ductus arteriosus that are being closed, I don't see this quick response of this authors have described in this article. It's usually, I believe that maybe this is due to the fact that the lung damage that the PDA has created still needs more time to resolve. So this is why I say that maybe we can use this to monitor response to treatments, but we need more studies to confirm this evidence, because in my experience, I think it's not that quick, but I don't have any publication to refute these results.
Thanks. Vikash?
Thank you, Almudena, for such a lovely talk. I'm I just wanted to find a few things, Almudena, regarding to the study which you conducted to find the correlation between HSPDA and your lung ultrasound scores. So which type of scores did you use? Did you use your conventional score, or because I probably didn't get that? Or
Sorry?
you use the one. Which type of scoring did you use? You use the score 0 to 3-1 without the
Yes.
plural line. Okay,
Yes, yes.
the conventional one actually. All right, because so we didn't include the plural line technique at all in that one.
Yeah. Maybe
All
if
right.
you take into account the plural line, maybe you can try to differentiate the
Mm,
which has more component
mm,
of BPD, the lung that has more
mm,
PDA and lung edema
yeah.
only. But
Mm,
we don't know that. There's no study
mm.
that have really
And
studied that.
probably that brings to the next question is, and probably you also mentioned about various people using various types of scores. Is there now a high time that we think about reviewing that conventional scoring system we use and
Yes.
start including the plural line? And I don't know whether we should have diaphragmatic excursion also or not in those scoring system when we evaluate.
Yes, we need an international consensus on the use of lung ultrasound scores, because if not, we can be conducting thousands of studies and each
Studies.
one. Yeah.
And
So
once,
there's now a consensus going on,
okay,
a worldwide consensus, including adult physicians and so on. So to try to get the universal consent lung ultrasound score to be applied in different studies.
thank you so much for that. I think that's a need of time. And my last question, Mahmood, if you don't mind asking me the third question, please, because I probably exhausted my quota. Is it all right, Mahmood, if I ask the third question?
Yeah, that's fine. Go for it.
All right. Very interestingly, this is the only study which I've seen where you've also put the correlation of diastolic. You have got so many parameters for diastolic dysfunction while you're assessing your PDA, like MPIs and your IVRTs and other stuffs. And what correlation did you find with this? That because my always worry is the degree of lung edema rather than as a direct cause of PDA. A lot of it is attributed by the diastolic dysfunction in extreme preterm babies, which I think so is the bigger culprit of causing pulmonary hemorrhage and lung edema than the duct itself. So did you had any correlation of your degree of pulmonary edema, lung ultrasound scores with diastolic dysfunction?
We don't have values of lung edema. We only have values of lung ultrasound score.
Which is probably reflective of your lung edema, right?
Well,
A bit of surrogate.
maybe, but it's also related to hypoventilation and inflammation. So in the idea is that in extremely low birth weight infants, we cannot say that high lung ultrasound score is related to lung edema. That's the measure. The final message of this talk, I think, because they also have some problems with the lungs that also
I know.
mimic lung edema in them. Maybe some of them have lung edema, but we are not able to differentiate in classical lung ultrasound score.
No, thank you.
You're welcome.
You got Sujis, then Ahmed, please.
Hi, Almudena. Can you hear me?
Yes, yes. Hello.
Yeah, hi. Hi, thank you so much for this excellent talk and sharing experience. I had a couple of questions. So I know your study where you looked at the various PDA parameters, it did not correlate with the lung ultrasound score, which is slightly different to the initial studies that you sort of mentioned at the start. Do you think, can you speculate why the PDA parameters that you chose did not show a correlation with the lung ultrasound scores?
I think this is because lung ultrasound score in infants born before 38 weeks in extremely very low weight infants also had to do with the situation of these infants of evolving BPD, inflammation, hypoventilation. Maybe some of them do have lung ultrasound, lung edema, but we are not able to differentiate this using classical lung ultrasound score. This is the idea. The idea is that in this population, you can only use lung ultrasound to rule out lung edema, not to rule in. That's the idea.
Okay.
The other articles, what they have done is they have described a hemodynamically significant PDA, and they compare lung ultrasound score between the two groups. But we all know that the sicker infant, the infant with lower gestational ages, will have more hemodynamically significant PDAs. But these infants also have the high risk of developing BPD. And we don't know what we are really measuring. Is this that we are measuring an infant with a more severe RDS, infant with evolving BPD, or an infant with hemodynamic significant PDA? We don't know that because we are not really getting these three groups, which I think is very important in this population.
But one of the things, Almudena, so among the three groups that you mentioned, do you think using the lung ultrasound score and doing the echo assessment to assess the ductors will help to tease the top, the top two from the PDA? That probably, so combination of the assessments may help with that.
That's what bikers asked before. I think that if you take into account the consolidations of the baby, the thickness of the pleural line, maybe you may have an idea of if the respiratory situation of the patient is related to HS PDA or evolving BPD. But we cannot really say that for sure. I don't know if you get, because more times both things are at the same time in the same patient, both PDA and BPD. So this is a bit challenging.
My last question, Almudena, is have you used a lung ultrasound score with diuretics to assess the management in infants with BPD, to assess response to diuretics? Any experience of using lung ultrasound scores?
Yes, we published this in 2020, I think. And if you use diuretics, you would see a decrease of lung ultrasound score just from the very first days of treatment in those patients that really have an improvement of the respiratory situation. Whether if this is due to diuretics or no, we cannot say that, but this is something that has been demonstrated. You can see the publication in Pediatric Pulmonology 2020.
Oh, fine. Thank you so much, Almudena. Thank you.
You're welcome.
Ahmed and Liam?
Hi, Almudena. Thank you very much for a very illuminating talk. So when I learned the topic of your talk, I was the question I thought you were going to try answer is that how does the lung scan, not just the lung score, help finding out whether it's a hemodynamically significant PDA causing the changes or the BPD? So we know that with BPD, there'll be a variety of findings, which you have already alluded to, the inflammation, the remodeling of the lung. So you have it's not just a score. There are consolidations, there are collapse areas, there are recruited areas, normal looking areas, bad areas. So it's not just the score I would do when I'm doing a lung scan. So you concluded saying that from a score point of view, purely, it may not be, there are no studies that completely say that it helps. It may be the same, but it's the total lung exploration that might still give you an idea that this is a scan with a certain score with a variety of findings suggesting BPD remodeling, whereas a more generalized wet lung pointing towards a PDA leading to a, is my understanding correct?
Yes, perfect. You get it perfect. The idea is that if you see a completely white lung without consolidations, with thin pleural line, that maybe the respiratory deterioration of that infant, if you have a PDA with hemodynamic significance detected in echocardiography, maybe that respiratory deterioration can be related to PDA. However, if you find thick pleural line, lots of consolidations, and so on, maybe that's not related to a PDA, more to a BPD.
Great. Thank you very much, Almudena. Again, it was a great talk.
Thank you. Very welcome.
I just want to say fantastic talk. Thank you. I really liked how you went through all the studies. I just wanted to ask, because about the hemodynamically significant PDA, I sort of, some of the earlier studies, I kind of, and I really applaud you for like all of the work that you did in your latest study of all the different echo parameters. I just one of my thoughts is just the earlier studies by using sort of predominantly ductal diameter and some of those other markers, that actually those might not be the best sort of markers of hemodynamically significant PDA. My only other question, and you did mention this quite a lot, is they didn't talk about sort of the respiratory status of the baby. Did they talk about sort of other markers, clinical markers of hemodynamically significant PDA as well? Because that's just what I was just wondering whether, you know, those kind of things influence the results. And it's sort of almost, as you say, they're going to do an international consensus on a lung score. It almost, well, I mean, you're probably not going to get this, but an international consensus on what markers make a hemodynamically significant PDA on echo, but that's probably going to be too much to agree on. But that was just, I suppose that was my question, but you've answered that in that they didn't talk about the clinical findings, but that was just my thought from some of the earlier studies that you were mentioning. But yeah, okay, that's really useful. Thank you for your talk. It was great.
Yeah, the idea is that they just created two groups, PDA or closed ductus arteriosus. And if you just read the results, maybe you can get to the conclusion that really lung ultrasound helps is differentiating that. But if you read more deeply into the methodology, you realize that the description of hemodynamically significant PDA are very, you know, like very, a definition are like very light. So, and very changing from one studies to another. You really have to pay more attention to this, because this is really important, I think.
Hey, hi, how are you? Congratulations. Hi, congratulations, Almudena. I really enjoyed your talk as always. So yeah, I think, and thank you very much, Liam, for your comment, because I was just about to say something about that. So, I mean, just thinking about that, PDA is not really an on-off phenomenon. I think that as well that you are using a score to predict BPD or edema. There are, at least that I'm aware of, 3 scores to know whether PDA can be hemodynamically significant or not. The Iowa one, a 5th one, and also we have in Madrid another one. I don't know which one is best, but at least I think that you could possibly find any relationship between the lung score with another PDA score. Because, you know, sometimes if you compare lung score with only one of the variables, echocardiographic variables, not all the PDA are the same. Some are large, some has diastolic dysfunction, some have quite a lot of still in the systemic circulation. But if you have kind of probably a score, whatever you want to find, and you just plot like your lung score with this PDA score, maybe, I don't know, you can find some correlation, even knowing that the edema in the small ones probably is related also with respiratory changes. Thank you so much.
Thank you. Very nice consideration. I think that's very helpful.
Yeah, and I think it's probably worth checking in many kind of future research the correlation with that, with the respiratory severity score, with, you know, saturation or SpO2, FiO2 correlation, those kind of things, just to see if that's actually affecting the clinical and the respiratory support. I'm sure we can just probably look back into those papers and try to tease out the numbers.
Yes.
We've got Liam. Is that a comment you want to say on your question or a new question?
It was actually just hello, Mike. I haven't seen her in a long time, so it's really lovely to see you. I didn't realise you were on the call. But also, I'm aware of the Iowa and the ELCAFE score. But if you had a score for PDAs in Madrid, I'm trying to sort out a scoring system in Bristol, and I was just wondering if you published that anywhere, or if that's something you could share.
Yeah, I mean, yeah, in Madrid we use a PDA score that use 4 variables. we use the diameter, we use the ratio between the systolic and diastolic velocity, we use the diastolic velocity in the pulmonary artery, and we use the diastolic velocity in the postductal artery, aorta. And with that, we have a score graduated to 1 to 3, and it is published in Frontiers of Pediatrics. And we have this score that is kind of a raw score, but you can plot also the gestational age with a formula, and you are going to have a predictive model to know the possibility of have a spontaneous PDA closure in 14 days in babies below 29 weeks of gestational age.
Thanks very much. I'll have a look in Frontiers for that.
Thank you.
Thanks, Maria. Anna, you wanted to ask something?
Yeah, mine was mainly a comment. First of all, thanks again, Almudena, for the presentation. It was fantastic. I think it just opens up an even wider conversation about how lung ultrasound can help us and better understanding the physiology of our patients. Because in this talk, we've been talking a lot about PDA, but I'm just thinking about all the other cardiac patients that we have in the units that are at risk of pulmonary overcirculation. And sometimes they're preterm or near term, they are in various levels of respiratory support. And then after 2, 3, 4 weeks, they're nice and stable. They suddenly have a deterioration in their respiratory status, and they might need more support or escalation of the type of support. And if you are thinking that maybe it's a pulmonary overcirculation, you might discuss with your cardiology colleagues, and often the answer is it's not the heart. And we had a few, because the primary thought is maybe there's an infection or there a consolidation in the lungs. And some of these babies, if they're preterm, you do an X-ray, it tells you everything and nothing. So we had a few cases where we actually discussed and thought, okay, should we do a lung ultrasound? And you have a better understanding of, especially if you have followed the journey of that patient with a lung ultrasound, you can confirm there's no consolidation, the lungs look exactly the same, but now there's a degree of increased V lines, and which in this case we can define it as a pulmonary edema. So it is primarily a problem of the heart. Sometimes it happens. So it goes to a wider discussion, but I think it's really interesting. And as you said, it would be fantastic to have what we are working on, so a consensus about the use of the lung ultrasound scores in this context, or a combination of scores. So thanks again.
Thank you, Anna. Very interesting comment. I think the main feature will be to have a serial evaluation of the infant, not just taking the picture when the baby gets sicker. Maybe that infant was getting sicker if you check the ultrasound before, and you are not able to really have the whole picture if you only have the ultrasound the day that the baby gets with the respiratory situation, the deterioration, sorry. So I think it's really worthy if you try.
And it's just anecdotally, because I was doing a lot of scans at the beginning, just to practice that. And there were a few babies where we could see, oh, there's some changes that I can see, but I don't know why. Then 1 or 2 days later, you see they have an incremental oxygen requirement. And I'm talking about babies with a risk of pulmonary overcirculation. So I do feel like somehow the lung ultrasound, again, I don't have enough numbers to confirm that the lung ultrasound can actually tells you which patient is gradually evolving towards a degree of pulmonary edema before the clinical aspect changes. Because some of these babies are already on some form of oxygen requirement, or sorry, not some form of respiratory support, like on high flow or vapor. So yes, maybe the monitoring aspect might be interesting, but again, it's just single cases that I'm thinking about.
Thank you.
Vikas?
I will hold on if anyone else, because my number has already gone. So I will wait for, if we have time, then I'll ask question. But I'll put my hands there.
Okay.
I don't want to be greedy.
That's okay. Any other questions from the audience for Almudena? Okay. It's your turn then, Vikas.
Thank you so much. Thank you so much. I could not stop myself put this comment, and because looking at your study, Almudena, you put it so beautifully well that when we are trying to interpret a score, we need to keep in mind so many other factors. Just trying to correlate a score without, and you've shown it beautifully that the lung ultrasound scores are influenced by so many other comorbidities which babies have, and that is why its significance is questionable. And the same thing I would say, if you think about, and this is what we need to do for the PDA score, people, because I've been using this various PDA scores for the last 2 years, and I have a huge case series, and we have submitted it for pass this year. The thing is that if you see the individual parameters of the score, like IVRT, in a significant large PDA, the IVRT is reduced. But if it is a coexisting diastolic dysfunction, the IVRT will be increased. So your decreased IVRT is nullified by your diastolic dysfunction. So we cannot use the IVRT parameter when there's a diastolic dysfunction. Same with LVO. If your LVO is LVO, if there is a large PFO, your LVO is significantly impacted by your large PFO. So interpreting LVO in presence of a large PFO is a questionable. Same thing with E waves, which they calculate. Again, that's questionable in presence of diastolic dysfunction. So I think so when we are calculating this course, we need to ensure that we can only use this course when you rule out this underlying pathology, unless and otherwise this course has no value.
Interesting. I don't have experience with that, but that's very interesting. Yeah. I don't know.
No, but that comes back to your talk in terms of that when using this core system for lung ultrasound, you need to keep this so many pathology at the back of your mind. And if you try and put correlations there, your correlations would always be a questionable correlation, whether it's true or not, because it has been impacted by those pathologies. I don't know what other people's experiences are when they use. Sorry, I'm digressing the topic, but it's just that I couldn't stop mentioning this.
Yeah. We tried to get correlation to different measurements, the whole list, because we really don't know how to measure an hemodynamic significant PDA. I think the best approach will be the one that Micah said. We correlate lung ultrasound score with the 3 or 4 or 2 different definitions published, but we were unable because in each of them we had some missing measurements. But this is why we tried to get a correlation with all single measurements that we had in our unit.
Yeah, I think the measures that you've used is definitely much better than just the diameter. It's more comprehensive. And I understand what Bikash is coming from. So because there are a few things that can interplay with the interpretation of the flow and the shunts and stuff like that. So you just probably it will affect anyway, but the degree of difference might point to more significant PDA rather than just a non-significant PDA, depending on what's going on with the baby. Yeah. Okay. Any more questions for Almudena? Okay, that's great. Thank you so much, Almudena, for taking the time to speak to us after coming back from a long journey. So thank you and much appreciated. And thanks everyone for joining. We will upload the recording on our YouTube channel and we'll see you again in a couple of weeks' time. All right.
Thank you. Thank you very much.
Thank you. Thank you.
Thank you for the invitation, Mahmoud. It's a pleasure.
Thank you very much. Take care.
Bye.